So next case is atrial fibrillation V5, very important topic. An 80-year-old man with no previous medical history develops breathlessness 2 days after open heart main procedure for perforated sigmoid diverticulum. His oxygen saturations are 96% on 2-liter oxygen. Respiratory rate is 22 per minute. Heart rate is 160 per minute. And his blood pressure is stable 110/50 mm mercury. And ECG demonstrates atrial fibrillation. So what is atrial fibrillation? So atrial fibrillation is a supraventricular tachycardia which is characterized by uncoordinated atrial activity. And if patient AV conduction is intact, then the ventricle also responds in irregular way. So what may precipitate post-operative atrial fibrillation? POAF, post-op atrial fibrillation. So starting from the lungs, hypoxia due to atelectasis, pulmonary embolism, obstructive sleep apnea. Then go to the CVS, hypotension due to hypovolemia, dehydration, fluid overload, worsening cardiac failure, coronary ischemia, severe anemia. Come to the electrolyte derangement, hypokalemia, hypomagnesemia, thyroid hypothyroidism, infection, sepsis, pneumonia, anastomotic leak, hypothermia, pain, withheld drugs of beta blockers particularly, and withdrawal of the drugs from alcohol, benzodiazepine and cocaine. How will you assess the patient? So this is a medical emergency, so patient should be assessed, investigated and treated simultaneously. The initial assessment of post-op fibrillation must determine the hemodynamic stability of the patient, assess for angina, hypotension, acute myocardial infarction or heart failure. Angina, hypotension, acute MI and heart failure. The patient is currently hemodynamically stable, so frequent assessment is required. So identifying and treating any reversible cause is critical. A rapid history physical examination should determine whether the patient has any previous cardiac paroxysmal atrial fibrillation, heart failure, reduced left ventricular ejection fraction, ischemic heart disease or pulmonary history, COPD. So missing doses of long-term medication such as beta blocker is unfortunately common and can precipitate post-orbital fibrillation. If this has happened, then this agent should be started as immediately as possible. Obtain a 12-lead ECG, full blood count, electrolytes including magnesium, glucose, renal and hepatic function, thyroid-stimulating hormone, TSH, perform chest X-ray, consider cardiac enzymes, and consider ABGs and CT pulmonary angiogram if PE is suspected. So what are the aims of the treatment? So 3 aims. Number 1, control of the rate with or without the sinus rhythm. Rate control with or without cardioversion or sinus rhythm. Number 1. Number 2, treating the precipitating factor. Number 3, assessment of the thromboembolic risk and initiating the anticoagulation if required. The patient is reviewed by medical register on call who administers IV metoprolol. Despite that, his heart rate remains at 160 per minute. His blood pressure drops to 80/40. So synchronized direct current cardioversion is required urgently. If hypovolemia is suspected, fluid resuscitation should also be initiated. The patient will need to be transferred to the HDU for cardiac monitoring. Patient with acute atrial fibrillation with rate above 150 per minute with hemodynamic instability like symptomatic hypotension, angina, acute MI, heart failure require immediate cardioversion. The patient is successfully cardioverted to sinus rhythm. How long should a patient who develops new post-orbital fibrillation be monitored for the acute event? For non-cardiothoracic atrial fibrillation, it should be 24 to 48 hours. For cardiothoracic surgery, it should be 48 to 72 hours. How can risk of the stroke due to the post-op atrial fibrillation can be calculated? So there is a formula, Chad's VAS score. So there are 2 parameters, age and gender, and 5 other systemic disease, including hypertension, congestive heart failure, stroke, peripheral vascular disease or vascular disease, and diabetes mellitus. So if someone has scored 2 or more than 2, they need anticoagulation. How is the long-term risk of bleeding with the anticoagulation assessed? So the bleeding is again assessed by another score called the Has Bled score. And this includes hypertension, age, liver function, kidney function, previous bleeding, predisposition, labile INR, stroke, drug or alcohol abuse. These risks should be discussed with the patient and his family before starting any anticoagulation. The medical registrar recommends starting anticoagulation when the surgeons are happy. What factors will determine when anticoagulation can be started? So anticoagulation does not need to be started immediately. A rule of thumb to estimate 2-day risk of major bleeding is it's 0 to 2% after minor or intermediate surgery that is lasting less than 4 minutes, general surgery, cholecystectomy, and 2 to 4% for major surgery lasting more than 45 minutes, cardiovascular surgery, orthopedic surgery, head and neck surgery. And the location of the bleeding can also be considered. The risk of complication of bleeding in the intraspinal, intracranial, ophthalmic, and cardiac surgery is high. Now, prophylactic anticoagulation can generally be initiated 6 hours post-operation in most cases. Full anticoagulation can be initiated within 24 hours of the minor surgery. However, after most major surgeries, full anticoagulation should be deferred for 48 to 72 hours. So prophylactic 6 hours and full anticoagulation for 48 to 72 hours for major surgery and within 24 hours for minor surgery. This patient should be observed closely for bleeding after anticoagulation has been initiated. Thank you.